here's kind of your breakdown in terms of if you had this marker, positive or negative, what do you do? And I've tried to spell this out as plainly as I can. A negative thyroglobulin is not diagnostic, nor is it positive. A negative thyroglobulin can partially rule out. A positive thyroglobulin, like I said a moment ago, has to be correlated with TPO to diagnose Hashimoto's and with thyroid receptor antibody to diagnose Graves, plus or minus ultrasound. And this is probably the most accurate way of using these. Although you do see debate in the literature, I feel this is the most prudent way to use these markers. And again, remember, this is because elevations can occur in healthy, in nodule, in goiter, and in cancer. And here's this first evidence point I wanted to share on thyroglobulins. To quote, on the contrary, a positive antibody for thyroglobulin is not diagnostic of Hashimoto's because thyroglobulin antibodies are found in numerous other conditions. They are present in approximately 50% of Graves' disease, 20% of non-toxic goiter and thyroid cancer cases, and also in normal individuals, especially older females. The titer of thyroglobulin antibodies does not usually correlate with the degree of thyroid dysfunction. This is why we want to use this marker as part of a larger diagnostic approach and not come to a firm diagnostic conclusion, especially for thyroid autoimmunity, based upon thyroglobulin alone. And here are two more data points that support this. The reason why I share a few different data points is in any body of literature, you're going to be able to find a couple outliers. But what the totality of the evidence supports is really what we should be looking to as the truth. So the NHANES data set, I'm not sure if this is what NHANES this was, but this sample from the NHANES was of over 16,000 individuals, and they found no significant association between thyroglobulin antibody levels and hypothyroid. And continuing from Frontiers in Immunology to quote, the functional consequence of anti-thyroglobulin antibodies is not clear as they do not cause thyroid cell destruction. These data points are why there is caution recommended regarding the interpretation of a thyroglobulin antibody alone. And this might be the most compelling data point that I've seen on why we want to be careful with how much diagnostic weight we assign to thyroglobulin antibodies. In this study, 223 adults who were previously diagnosed with Hashimoto's were examined for a correlation between ultrasound findings and thyroid antibody findings. If the antibodies are accurate, we should see correlation between the antibodies and the ultrasound. Now, one can argue, well, antibodies may elevate before the ultrasound changes, and there may be some truth to that, but I think it misses the bigger point, which is if we look at enough people, we will see people at different time points in their course of the antibodies being positive. And at least according to my inference, with a large enough sample size, and I've showed you multiple now, we should either see a correlation or not. And that sort of predictive antibody hypothesis doesn't seem to hold weight if we have a sample size that's large enough. And remember, the NHANES data was over 16,000 individuals. In this study, they're looking for a correlation between, again, ultrasound and antibodies. Now, the TPO antibodies correlated with ultrasound, but the thyroglobulin antibodies did not correlate with ultrasound. What you're seeing here is essentially a quote. Now, it's a little bit wordy, but let me break it down. Hypoechoic echogenicity. This means that there's not enough reverberation or echo in the thyroid gland. Remember all those follicles? Those follicles should have a fair amount of echo, what's known as isoechoic, or the appropriate amount of density as discovered by the ultrasound. Hypoechoic means that there's been some damage from these antibodies and therefore inflammation or scar tissue, and that has a denser finding or a denser sort of resonance. So the low level of echo was associated with TPO. However, thyroglobulin levels did not show any differences, and there were no significant correlations between sonographic variables and thyroglobulin levels. And here's the visual representation of that. This is a normal thyroid ultrasound. This is a aberrant or a Hashimoto's ultrasound. And what you're seeing is isoechoic, meaning it's the appropriate level of echo, meaning the tissue is not overly dense, and you're seeing homogeneity. It's similar. Isoechoic homogeneity of the gland. This correlates with TPO, not with thyroglobulin. And here what you're seeing is this hypoechoic. You're seeing these pockets of density. As you can clearly see, the tissue is not all the same. Picture that you were rubbing your bicep. You shouldn't feel bumps, lumps, or hard spots in there. The tissue should all have a consistent feel to it. That's what you should be having in your thyroid gland. So in this aberrant ultrasound finding image that you're seeing, the thyroglobulin antibodies were normal. So here they're normal when the tissue is being damaged, and they're also normal here, right? So normal thyroglobulin, normal TPO, abnormal TPO. So this is exactly why the numerous papers that we covered are essentially recommending caution and spelling out that thyroglobulin in and of itself is not diagnostic. And this study I thought was a really wonderful visual portrayal of that.